Good morning, good afternoon, good evening to our audience watching this Getting to Zero episode from different time zones. And today I'm speaking with Dr. Zainab Bagudu, a highly accomplished cancer expert and advocate who heads the First Ladies Against Cancer organization in Nigeria and is also a board member of the Union for International Cancer Control. If you are interested in knowing about our future conversations, be sure to like this video and also subscribe to our YouTube channel below. Dr. Zainab is a very passionate and tireless champion of gender equity in health and highly engaged in screening and treatment for women's cancers, particularly in rural communities of Nigeria. Welcome, Dr. Zainab Bagudu.
Thank you so much for having me on your chat today, Anuradha. It's a pleasure to be here. And thank you also for the work you're doing in making sure that we have vaccine equity and especially in women's health around the world. Thank you.
So, Dr. Zainab, you are incredibly active in cancer awareness and advocacy in Nigeria and beyond, as I already said. But what are your biggest concerns about the current situation for women's cancers, and in particular, cervical cancer, which is now a top cause of death for women in Africa?
Yes, women's health generally is a cause for concern. There are very few or little funding that goes towards women's health, in particular, women-only diseases. And cancer is one of those areas where you have cancers that differentiate by gender. By this, I mean the common ones that we know that are causing a problem for us are breast cancer, cervical cancer, and then we have ovarian endometrial cancer. So these cancers tend to be in my own area of operation, we can see that there is very poor awareness across the spectrum of cancer control. The awareness is low, there's little knowledge, and most importantly, access to facilities that will help women to diagnose and to treat these cancers are very poor, so that the mortality rate is really high. The global incidence of cervical cancer is about 300,000. 300,000 every year. In Africa, we have 80,000 women die every year out of the global figure. So you can see that there's a large chunk of it that comes out of Africa. And by the way, these statistics that we're quoting are probably underreported. And like you famously said, and I always quote it, there are many more women that are going undetected, undiagnosed, and untreated that we don't have a record of. So those are the issues that we have across the spectrum. Those are the main issues. Access to care, access to diagnosis, access to palliative care is a problem. The lowest hanging fruits, which we don't give as much attention to, is the awareness and the education that we need to impact on our people. Of course, the health systems are weak and can be stronger. All these things are related to funding, but the awareness is really poor.
Yeah, so thank you for this, Zainab. And we are hearing it over and over again from a wide-ranging set of stakeholders that education and awareness really are critical prerequisites of success. You have also often spoken about the difficulties in accessing services for diagnosis and treatment of cancer in Africa, and have opened a diagnostic center yourself. So do you see technological advances such as self-testing for HPV as useful or important, something that can help us leapfrog from very low rates of VIA screening to very high rates, 70% as stipulated by WHO? And what are the biggest barriers that you see when it comes to cervical cancer diagnosis and treatment?
Okay, so there are some new innovations, of which self-care and the self-sampling kit is one of them. The screen and treat with the cryotherapy is also another one that has been widely used in programs. They are important, very much so, as long as we contextualize them and we find a way to, again, educate the women that we're asking to use these innovations in a way that they're comfortable with. And it depends on which part of the world you are. In the Western world, and even in some parts of Nigeria, the self-sampling kit has been more successful. We don't have the actual figures yet, but in the northern parts, primarily where I operate from, it has not been as successful. It's not as accessible, it's not available. The idea of self-sampling is either you do it, in Lagos, what they do, which is in the south and the capital, the women go, they pay for the kit, and the cost of the testing is already embedded in whatever they pay. And then they do the sample there, or they take it home, do the sample and return it. So there is a delivery service as well. We don't have all that support system that is going to pick up that logistics system that will pick up the kits, deliver it. And then most importantly, most women in the northern culture are not comfortable with sticking things up themselves. So we found that even in facility, when they're observed by a healthcare professional, they tend to be a little shy. It took a long time for us to get women to talk openly about breast self-examination because it's looked upon as this sort of sexual self-gratification. So there was a lot of preaching by the religious leaders, and we're still at that. So I'm not ruling it out in any way. It's definitely very useful for a certain population and less so for the rural communities. How are they going to move it into the labs and to the labs that are going to test it? How are they going to have a delivery person pick it up? And then for the moment, it's still only obtained in a private setting. It's not available in the public hospitals, so definitely they won't be able to afford it. Which brings me to the next part of your question, where you asked about the barriers to cervical cancer. Funding has to be a huge barrier. Human capacity, we're seeing a lot of human resource flight in an already inadequate environment and atmosphere, where even the community health extension workers are not enough to man the primary healthcare centers that we have. There have been various attempts to institutionalize screening, the screen and treat program. The UNITAID program ran for about 4 years in Nigeria, but it's come to an end and it hasn't been continued. Some states say they've continued it, but not at the scale at which it has been, because obviously government is prioritizing different things and the funding for that is not available. Cultural barriers, I've spoken about that, human capacity. So I'd say those are the main ones. The diagnostic capacity is there, especially after the COVID-19 pandemic. That was built up. Lots of countries and partners came together, joined hands, and built up not just a vaccine for COVID, but the capacity, the molecular testing capacity of a lot of countries. When COVID started, we had just one molecular testing laboratory in Nigeria, aside from the ones doing HIV with the gene experts. And by the end of COVID, every state had at least 2. So it's widespread, it's available, but it's just not channeled towards use for HPV testing. And we need to create more demand and generate demand for not just the vaccine, but also the screening and early treatment.
Yeah, so you highlight very important issues, and particularly this imperative of looking at the infrastructure which was created and built during COVID-19 and a variety of ways in which it can now be channeled for the benefit of community. But let me pick on the first part of your response, Zainab, and reflecting on your advocacy for rural oncology. You rightly emphasize the importance of cultural norms and also finding ways to bring care to the community that resides not in cities and urban centers, but really in the hinterland. and a huge variety of issues that they are confronted with. So please share with us, what are some of the best practices that you have seen to overcome some of the local hurdles that you rightly spotlighted, such as informing and training community health workers, and also some effective ways of including and engaging local leadership, because they are the ones who would bring in change?
Yes, absolutely. It's very important to work with the local leadership, the community gatekeepers. And unfortunately, a lot of programs, or when the programs, initiatives, and interventions in cancer across the development space, they don't tend to always have that community buy-in or engagement from the beginning. That is changing a lot more now, thankfully. But typically, to have the traditional rulers have a representative in the room when the programs are being designed is not the norm. So having partners that are going to engage, and there are some capable people amongst them. Yes, there are different levels, but there are some capable ones that are able to understand, and they can understand what we're trying to do and will give us advice on how best to achieve it. Also, there tends to be focus on the output. For instance, if we look at the HPV vaccine, we want to vaccinate 7 million, 3 million, 2 million girls, depending on where we are. I think the global thing is 86 million now. But how much are we putting towards investing in the system, in the public health system and the administration? Electronic health systems are practically non-existent here in most rural communities. And how are we going to strengthen those systems to make sure that they can really have an impact on what we're trying to do? So that doesn't really happen. And so you find that the human resource, the infrastructure remains the same, and we bring in the vaccines. There have been some exceptions. We had a very good program in Gavi, by Gavi in Kebbi, that gave all the refrigerators. They gave the solar-powered refrigerators, and that's excellent. It totally turned around the immunization statistics of the state, because they were able to fix the logistic chain, and the whole chain improved. But that's not normal. And also training and retraining the healthcare workers about how they should handle the fridges, what we're trying to achieve, reporting, getting the right data. So those are all ways in which we can do better. Funding is a big problem now in Nigeria. I'll tell you why, because we've recently had a law passed that says funding for the healthcare system has to go directly to the local government. So we have the federal government, the state government, and the local government. So the least capable, where you have the least capacity, is at the local government. But they have a huge amount of funding that is now taken out of control of the state's leadership. So how are they going to utilize that funding? How are the partners going to, because partners bring their own, some is funding, sometimes it's in devices and all sorts of consumables, but the funding for the state gives a counterpart funding that's going to fuel the vehicles and pay the workers and things like that. So that is going to be now domiciled at the local government level. And we're talking about, 700 local government chairmen. I don't know how those are going to be engaged as opposed to 36 states. So that's a problem that Nigeria is going to face now. And then benchmarking. We often hear of funding coming in for different programs. Recently, there was a global commitment to increase funding to cervical cancer, I believe to the tune of 600 million from different partners, the World Bank, Gates, and so on. But the fund goes to the countries, and it's not benchmarked. It's not fenced around any particular disease. The countries will decide. I just found out, sadly, I was one of those that celebrated 600 million coming to cervical cancer. only to hear that, yes, Nigeria has received it's either 40, 50, whatever million, but it's up to us to do what we want to do with it. So unless advocates like myself actively engage government and make a lot of noise in the right way, in the right corridors of power, we're not going to see that funding used for cervical cancer elimination.
So I hear you actually emphasize four key points. One is the imperative of adopting a systems approach as we chase targets, because even if targets are met, sustaining continued high coverage is going to be a challenge if the system falls apart. The second, I think, that you rightly highlighted was this whole challenge of institutional capacity that follows devolution. So while we all celebrate decentralization and devolution, the kind that is now happening in Nigeria, with funding going directly to local bodies, if local bodies do not have the right governance or institutional capacities, then it can actually backfire. The third thing is really prioritization and priority setting. So Cartagena meeting announced 600 million worth funding for cervical cancer. But when you start to peel it, then you find that priority setting still rests with the decision makers in countries, and they therefore need to prioritize women's health and issues like cervical cancer. And the fourth very powerful thing that you said was that while we have funding for vaccination from global funds like Gavi, secondary prevention is an aspect where we don't have structured, systematic scale of funding. And that is where a domestic budget will have to play an increased role, for which political advocacy will be key. So let's just change tack, Zainab, and really focus now on research and data needs. And I've often heard you say that research and data not only inform our strategies and interventions, but also drive innovation and improvements in patient outcomes. So what do you think are the greatest data needs in cervical cancer, and what would top your wish list for research?
Well, I'd say some more implementation research, how we can implementation science in LMICs where we are, because there are a lot of best practices that have been proven by evidence-driven data, and they're really best practices and it works, but they are in high-income countries. How do we contextualize that? We need to test it and research that these methods are going to work for us in LMICs. So implementation science, some more data on that, and strengthening our cancer registration system is another that is indirectly involved in research, because without the right data, then we're not going to be able to do much with the implementations. And thankfully for us in Nigeria, we've recently seen some efforts in that direction. There's the National Institute for Cancer Research and Treatment was started about a year ago now, and they're doing a lot of work in terms of the research, getting the registries together, capacity building for the registries. There have been efforts, pockets of different types of efforts in the last 10 years, I'd say, but to get it up to par so that we have cleaner data coming out of the country, very important. And then also, for me, one of the things that I think, again, I'm an advocate, so I always put the patients in the center of my conversation, is having the patients in the room also when we're talking about these researches. It's very funny to imagine that it was just this year at the 77th World Assembly that WHO passed a resolution that was to that effect, that says that we must include the social and the society for us to have, just in short, having the patient's voice in the room. So I think it's important that even when it comes to research and data, we have to include the patients and all the other things of building capacity, trying to strengthen infrastructure, and how our academia are thinking and how they're able to conduct their clinical trials, giving them those strengths to be able to do that. I've recently developed a love of artificial intelligence. I think it's the future, and I think it's going to be the answer to a lot of our solutions because of the way it works. Again, for us to do that and for it to be effective for us where we're sitting and other low middle income countries, it's important that we contribute the right data to the models that are being created. Currently, I read that only about 2% comes out of Africa, and that's not good enough if we're going to be predicting how high our chances of getting breast or cervical cancer is from an AI model. Then we need to put more data in there. So I've been working with some groups to make sure that that happens.
So what you are saying about local level research will involve a huge paradigm shift from the current approach, where everybody has to be strongly vested in the whole idea of localization, with power, ownership, resources moving into the hands of local people, including researchers and academic institutions. And you know that at the Global HPV Consortium and Sabin, we are very deeply vested in this whole idea of localization. So Sabin does not believe in opening its own country offices, but we really are very focused on harnessing the potential of local agencies, local actors, and people who are closest to the problem. And that is how we envision a world where solutions are rooted in communities. So in your experience, what are the key elements of localization that most global organizations miss today?
Well, I think we've mentioned some of them already. It's about partnership. It's about having the local bodies in the room when the decisions are being made to carry out these programs, and giving them not just being in the room, but having equity and being able to make the decision and to speak to the issues at hand in the right way. Again, considering more of the system and less focused on the output that we're trying to achieve, strengthening the system and ensuring. So I think that whilst organizations like Sabin are doing very well, we need to prioritize that local input in terms of resources. How much resources do they have to ensure sustainability of the programs that we're bringing, not just financial, but also human resources. Build the capacity to that level and consider very much so the cultural barriers and social norms that exist in that area to ensure that we're able to carry on with the programs that we're bringing. It's really just making sure that we're taking the grassroots to the high level, making sure that the voices matter.
So let me follow on with probably the toughest question. What are the three most needed changes to truly bring equity in healthcare to Africa?
Well, I would say education is the first one. It doesn't matter if you throw all the money in the world at a problem if the person you're trying to help doesn't understand. So we need to do more in terms of education and awareness and letting some people still don't believe that cancer exists, or at the most they say it's a disease for rich people, in my immediate environment. So we need to do something about that. Have more civil action, civil society, speaking to our populations and making sure that they understand what we're doing. Yes, we need resources in terms of human resources and financial resources to be able to overcome it. Some cervical cancer is leaving us with 1 million orphans every year. So if we can make the economic case for empowering women and making them more able to make decisions that matter, especially to their health. They're such a pivotal part of the community. In many communities, the women are the breadwinners. The whole family focuses around them. They're the primary caregivers. They're the ones that will go to the hospitals and so on. So empowering our women is also a way forward. I'm a strong believer in women empowerment for overcoming our health hurdles. So that's another place where I think partners can really help when we emphasize or when we give this partnerships or we go into funding partnerships. There's always the components that we can include some form of women empowerment and gender equity, making sure that it's balanced and the women's health also gets noticed in what we're trying to achieve.
So thank you so much for those four things, that you so beautifully captured. One is education. Education is what unlocks the potential of societies to think, creatively, but also equitably. And the second thing about, targeted investments with regard to areas, which enhance equity. And really then women empowerment, right? How important it is to prioritize issues with regard to women, but also enhance the agency of women, and really for the governments to take that ownership and make the requisite and commensurate investments. Dr. Zainab, thank you so much for this wonderful, wonderful conversation. I'm sure our audience are going to be delighted and with a lot of very insightful inputs that you shared with them, which are really coming from your own wealth of experience that in turn is rooted in communities. Thanks a lot.
Thank you. I appreciate it.
Thank you. Thanks a lot.